Dear colleagues, dear friends, thank you for being with us this afternoon for the first webinar organized by the European Society of Gynecology. The European Society of Gynecology will have its own Congress this year from the 29th of November to the 2nd of December. And in the meantime, we have decided to activate our webinar series, who will promote the evolution of gynecology in the various chapters and various areas. Today, we have the pleasure to speak about a very hot topic, which is the luteal phase in IVF cycles. You know how great was the debate, how great was the discussion, and how important are the achievements that we have obtained. And we do that one with two masters. One is Peter Humaidan from Aarhus. The other is Pedro Barri from Barcelona. As always, I will start introducing first Peter and then Pedro. We will have the two presentations, and after that, we will have the general discussion. Please, I remind you that you have to write your question in the question and answer chapter. I will see the question, and I will introduce the question to the various speakers. And also, both speakers can also discuss if they have any other point to clarify when the other speaker is requested to answer. Peter Humaidan is a specialist in reproductive endocrinology and professor at the Fertility Clinic, Skilve Regional Hospital in the Aarhus University in Denmark. His main fields of interest are triggering and ovulation with GnRH agonist, the role of LH during the follicular and luteal phase, and the role of female genital tract microbiota for reproductive outcomes, ovarian hyperstimulation syndrome prevention, the role of sperm DNA fragmentation for spontaneous and anticipated reproduction. He is the founder of the International Society, the Copenhagen GnRH Triggering Workshop Group. Thank you, Peter, for having created that one. It was a big achievement. We introduced the GnRH trigger in modern IVF, changing trigger policy worldwide. I thank you very much for your presence today with us, and you have the microphone.
Thank you very much. So now I'll just get this going. Thank you very much, Andrea, for this kind invitation. It's a great pleasure for me to talk to all of you today. And dear colleagues, I hope that you haven't completely lost the interest in webinars. We had a lot of webinars during these COVID times, but I still think that webinars can still do something interesting for all of us, and we can sit at home and we can learn. Now, what I'm going to talk to you today about is the luteal phase physiology if we compare the stimulated versus the natural cycle. So what I'm going to go into is obviously, first of all, the luteal phase of the natural cycle, and also to show you how closely connected the ovulation trigger is to the luteal phase. We're going to look into the luteal phase after HCG and agonist trigger, and we're going to unravel the correlation between mid-luteal progesterone and reproductive outcomes. So Pedro is going to talk to you about mid-luteal progesterone in frozen embryo transfer. I want to take you into a new field, mid-luteal phase progesterone in fresh embryo transfer. Probably not a lot of you are monitoring your luteal phases of the fresh embryo transfer, but I predict that this is where we will be going in a few years. Now, to cover all these issues, obviously we need to go into basic endocrinology. And here, what we are talking about is obviously the mid-luteal phase, in which we have the mid-luteal rise in progesterone and in estradiol, but also in hydroxyprogesterone. Remember, hydroxyprogesterone is about 1/3 of progesterone, but its action, the action of this hormone, is exactly the same as for progesterone. What we learned many years ago is that the luteal phase of all stimulated cycles is disrupted because we have many follicles producing a lot of steroids, and these high steroid levels in the early to mid-luteal phase will suppress the endogenous release of LH. Now, if we compare the LH or LH-like activity in natural cycle in white versus the release of LH and FSH after an agonist trigger, you can see a very, very different pattern. You have the agonist in yellow, in which you have a peak of after 4 hours, and then a long descending limb of 28 to 32 hours. So in total, the total duration is around 28 hours. Now, if we go for the natural cycle, you can see that the profile is completely different. We have a long ascending limb of 14 hours, a plateau of 14 hours, and a long descending limb of 20 hours, a total of 48 hours. And you have to imagine that during this time, LH, but also FSH is secreted. So just by seeing this, we can all see that the area under the curve of LH and FSH secreted after agonist trigger is significantly less than during the natural cycle surge of LH. So what happens when we add HCG? Well, we add a highly supraphysiological LH activity bolus, because please remember that we use HCG as a substitute for LH, because HCG will attach to and activate the same receptor, the LH-HCG receptor, but HCG is around for several days after trigger. You could ask yourselves, well, Peter, which levels are we talking about during mid-luteal phase of LH? Well, around 6 IU during natural cycle, and after an agonist trigger, significantly lower. We learned this the very hard way in our first study in 2005. You can see that the LH level is reduced by 75%, only 1.5 IU per liter. And in that same study, in the control group, we triggered patients with HCG. And you could say, come on, LH is even lower. Yes, but they had HCG around to cover up for the LH deficiency. And the reason for the low LH was high progesterone induced by the HCG trigger. Why do we care about LH? Well, LH is pivotal for the role of the corpus luteum. It's completely responsible for the stereogenic activity. It also, LH upregulates growth factors like VEGF-A and FGF2, which both of them participate in early implantation in terms of neovascularization in the endometrium. We also know that LH upregulates cytokines involved in implantation, and LH, or the LHCG receptor, also participates in the crosstalk between the implanting embryo and the endometrium. So completely crucial roles of LH. Now, if we go back to this excellent study by Filicore, it's highly referenced. If you look to the upper panel, you see the LH and you see the LH peaks, and in the lower panel, you see progesterone and you see the progesterone peaks. What I just wanted to show you, and what Marco wanted to show in those days, was that for every LH peak, it will be followed by a progesterone peak. This was one thing, but also that there's a huge variability in progesterone, also because the cyclicity of the peaks of LH vary from hour to hour. So you see at the lowest, progesterone is around 7, but at its highest during natural cycle, it's around 35, and now we are talking nanogram per mil. But the mean during natural cycle is around 10 nanogram per mil of progesterone. Why do we care of progesterone? Well, because progesterone opens the endometrium, will transform the endometrium into the secretory phase and regulate the so-called window of implantation. Progesterone also increases endometrial vascularization to facilitate implantation. Progesterone also works as an immunolator. Imagine you have 1,000 times higher level of progesterone inside the follicle as compared to serum. And the reason for this is that when the ovulation takes place, the oocyte will be flushed down the tube in an ocean of progesterone, which takes part in protecting the embryo during the passage of the tube. And then finally, we also know, which is important for our job, that progesterone will reduce uterine contractions around peri-implantation. So a lot of people would say, well, why don't we just go for natural cycle, because natural cycle should be perfect. And I'm sure Pedro is going to go deeper into this. I just want to go into the physiology surrounding natural cycle. Here, 2 patients, 3 cycles, and you see on the y-axis the progesterone in nanomolar per liter, and on the x-axis you have the cycle days. What I just wanted to show you here, these ladies are normal cycling ladies, and for both of them it's very, very obvious that only 1 out of 3 cycles actually reached the 30 nanomole or 35 nanomole per liter, which is similar to 10 nanogram per milliliter. And we know from many years ago, this was Michael Hall who found that the lower limit for natural conception in a large observational trial in patients who were trying to conceive, that the lower limit was 9.4 nanogram per mil. So maybe some of us found that we found gold, but remember, everything is forgotten after 10 years. So Michael Hall already 40 years ago came out telling us that 10 nanogram per mil should be what we were aiming for now in our frozen embryo transfers. And he was so right. Another 2 patients showing exactly the same pattern. A corpus luteum is not just a corpus luteum. There will be cyclic variability, and maybe this is the birth control pill by nature. We saw this, and Pedro is going to show you this, what the importance of when you use a natural cycle for blastocyst transfer. In this study from Pedro's center, you could see that 37% of patients were lower than 10 nanogram per mil, quite compatible with what I showed you just previously. And those who were lower than 10 nanogram per mil had a reduction in their live birth rate of 15%. And this is obviously why, if we do natural cycle, we cannot rely on the production by corpus luteum alone. We need to add, if we don't monitor, we need to add exogenous progesterone for frozen embryo transfer cycles. Now, how much progesterone do we need for the window of implantation and to secure the early implant? This highly sophisticated process in which HCG and progesterone and prostaglandins and VGF are involved. Well, what we know is that we have the cutoff levels for frozen embryo transfer. We're going to hear more about those later. The lower cutoff is 10 nanogram per mil. Remember the Michael Hall study? But we have been working also now quite recently in trying to find cutoff levels for fresh embryo transfer. To do so, we have to look into the luteal phase. This is a 10,000 units HCG trigger. And you know, we all believe that if you gave 10,000 units of HCG, the HCG would be well around until day 8. And this is the time on in which the embryo produces sufficient amounts of HCG to support the function of corpus luteum. Remember that the corpus luteum is completely relies on LH or HCG activity. But is this true? Well, if we look into this elegant study from Weizmann from '96, these are 2 patients, 2 different patients, A and B, being treated with 3 different ways or doses and administrations forms. So in the upper panel, this is 10,000 units of progesterone subcut. This is 10,000 units intramuscular, and this is 5,000 units intramuscular. Here you see the serum levels of HCG. What you see and what is quite obvious is that the subcut administration secures in both patients the highest HCG level and also with the longest duration. But please also note the serum levels. Patient A, the peak is around 280 IU, 280, but patient B is around 1,100 IU. So our patients will respond differently to the trigger. Maybe this patient, the patient A, was an obese patient. We don't know. So when does the embryo implant? Well, actually, when there's no more HCG around and when progesterone is on the descending curve. So recently we did this study now looking into 6,500 units HCG trigger in 160 patients. What we see here is quite interesting. We reach a peak of HCG of 120 IUs at 24 hours after the trigger. The progesterone peak is reached at oocyte retrieval plus 2 days, and it's around 60 nanogram per mil. Now, after 6 days after the oocyte retrieval, there's no more HCG around, and you can see that progesterone is on the decline at a time in which the embryo is actually implanting. At the same time, LH is very, very low because progesterone is very high, so we have a negative impact of progesterone on the pituitary leads of LH. So what we are showing is actually the difference between the hyperstimulated cycle and the normal cycle. Here you see the progesterone of the hyperstimulated, and here the normal cycle. What we know, and which is important, is obviously that the peak of progesterone during natural cycle is around the mid-luteal phase, around the time of implantation, which is here. But when we do our trigger, we advance the peak of progesterone. This is what I call the tsunami of progesterone, which could cause advancement and of the endometrium, and it's definitely not physiological. So in a magnifying glass, you see the same wave here, the tsunami. You have at trigger less than 1.5, already 12 hours after, you can see that the progesterone level is now around 15, so 10 times higher after 12 hours, and then the peak is around 60 nanogram per mil at oocyte retrieval plus 2, and then we go down. So this is the reality after HCG trigger. We have HCG around for 6.5 days, and then progesterone starts going down, and this is why we need to add some progesterone in the stress transfer cycle at this time point. In reality, we did not need any progesterone here because, as you remember, we have high progesterone levels, but we are quite simple in minds in IVF. So instead of saying, well, let's just wait till the mid-luteal phase to add exogenous progesterone, it's easier for our patients definitely to remember to start on the evening of the oocyte retrieval or the following day. But in reality, the period in which we need the luteal phase is from, let's say, day 6 after oocyte retrieval until the day of the pregnancy test. Because if this implant works well, the HCG from the implant will definitely secure the progesterone production by the corpus luteum. So what about the agonist trigger? Well, again, you see 160 patients. We were doing a dose-finding study using different doses, and the message is here, there's no difference in the search, whatever you use, 0.2, 0.3, 0.4 milligram of triptorelin. But what I wanted to point out for you is that you can see that the peak of, this is now LH, is around 130 IUs 4 hours after the trigger. The following morning, 12 hours later, you still have around 55 units of LH in circulation, and at 36 hours, there's no more LH left. If we go for progesterone, you can see that the highest progesterone is around 20 nanogram per mil, and it's achieved 12 hours after the trigger, and then it's more or less constant until between days 3 and 4 if you don't add any exogenous progesterone or boost like we do with small boluses of HCG. You will then have a complete demise of the corpora lutea. So what about the FSH? Well, just to show you, if you have a nice stimulation, these are the levels that we reach, around 20 IU in serum. This is the stimulation. And now when we trigger, what we reach of FSH is around 40 IU after the trigger. So this is what the early luteal phase after an agonist trigger looks like. After the initial surge of LH and FSH, we had a long LH activity deficiency period with low progesterone. So just to sum up, when we use an HCG level, 6,500 units, the peak level will be 120 IUs. And remember, if we compare LH to FSH, 120 units of HCG is comparable to 720 units of LH activity because HCG has a 6 times higher bioactivity than LH. For LH, the peak is around 130 units of LH. So look at this, 130 units versus 720 units, highly supraphysiological. It keeps around for 4 hours. This is the peak. You still have 55 units after 12 hours and back to baseline after 24 to 36 hours. And if we don't rescue the corpus luteum by either agonist boluses or HCG boluses or LH, we will have a complete demise. And this is what we experienced in the early studies, in which we were just supporting with vaginal progesterone, which was definitely not enough to reach the cutoff that I'm going to talk to you in a minute. Because do mid-luteal progesterone in fresh transfer predict live birth? Well, we did this study, an observational study of more than 600 IVF ICSI cycles, and we did logistic regression analysis. And I want you to look at panel F. This is now adjusted odds ratio for live birth compared to the mid-luteal progesterone level, and these are nanomolar per liter. What you see is the typical bell-shaped curve. You can be too low, but apparently you can also be too high, although there were very, very few patients who were above 400 nanomolar per liter, which is around 110 nanogram per milliliter. But what we see is that if we compare the best live birth rate, which is around 50 to 80 nanogram per mil, there's a difference of approximately 12% to those patients who were lower, and 16% lower live birth rate in those patients who were higher. So again, an indication for an optimal progesterone cutoff level. Now, what was more interesting was that 50%, more than half of our patients, were outside this panel, and the majority were either in the very suboptimal or in the medium suboptimal group of patients. This finding was subsequently corroborated in more than 300 cycles performed with Dr. Benamashis in Algiers. And what we saw here was again that the optimal level in his study was around 40 to 60, which is very close to 50 to 80 that we were finding. Remember, different assays, different laboratories analyzing, and you can see that the odds ratio is 2.7 in favor of live birth if you are within this interval on the mid-luteal, during the mid-luteal phase, on the day of the blastocyst transfer. So should we monitor? Well, obviously, I cannot answer this question. We are just doing it experimentally now, but what we saw in this small patient study in 10 IVF patients, and you can see this is a study which is hardly impossible to do in Europe today, 10 patients having repeated blood sampling every half hour from 6:30 in the morning until 9 o'clock in the evening. And on the y-axis, you have the serum progesterone, and here you have the cutoff of 150 or 50 nanogram per milliliter. And you can see the vast majority of patients are above this. But if we go into details to look into these patients, we can see that this patient in the upper panel, who had a very high progesterone level of 400 nanomolar, she had 11 follicles and a 6,500 units HCG trigger. Whereas this patient, who is here in the yellow, in the green line, in the suboptimal group, she had 10 follicles and a 10,000 units HCG trigger. Just to tell you that you cannot say from the number of the follicles and the trigger how your patients are, which level your patients are going to be. But the very important thing here is that if you are in the optimal level, you will always be there. If you are very low, you will be in the very low level. And for instance, patients 7 and 8, those patients who are red and blue, they had 15, respectively 17 follicles. They were triggered with HCG, and the only progesterone they had in serum was the one which came out of the vaginal support, that is approximately 10 nanogram per mil. They had no function of all these corpora lutea at all. And if we don't measure, we're never going to find these patients. We will say to each other, this is odd, because we all have these patients. This patient only conceives in frozen embryo transfer, never in fresh. Well, the reason is, for many of these patients, that they have a corpus luteum problem. in fresh. So did anyone do intervention? Well, this is the only study. It's a quite recent study. It's out of China, 1,500 cycles nearly, long agonist downregulation triggered with HCG. These patients received a day 2 embryo transfer. And patients had vaginal progesterone 90 milligrams once a day. And then the study was looking into serum progesterone on the day before transfer, that is the day after pickup, and embryo transfer +6, which is oocyte retrieval +9 if it's a day 3 embryo, and it's day 8 if it's a day 2 embryo. So quite late. What these authors saw was that there was no difference in progesterone on the day before embryo transfer, because remember, you have this huge surge of progesterone at this time. The problems will appear in the mid-luteal phase when progesterone goes down. But then on embryo transfer +6, they were able to categorize 5 groups ranging from 0 to 10 nanogram per mil and more than 40 nanogram, which is the reference level which they wanted patients to have according to our previous findings. Those patients who were low, they tried to rescue with oral dydrogesterone 10 milligram twice daily from embryo transfer +6, which is quite late again. And you can see it's nearly 1/5 of patients in their study group who were very low. So what happened? Well, just to show you here, you have the live birth rate on the y-axis. You have the serum progesterone, the mid-luteal serum progesterone. Here you have the reference level more than 40. Here you have the patients who were rescued with oral digesterone. They end up with very good live birth rates, nearly too good, but extremely high live birth rates, whereas all the others are lower. If we go for early pregnancy loss, we see the same pattern. Here, the reference more than 40 nanogram per mil. Here, the rescue patient, whereas all the others, the lower the progesterone, the higher the early pregnancy loss. So just to conclude, for me, I think that the future, the near future, will contain mid-luteal progesterone measurements also if after fresh transfer, because this will be the way that we can increase our reproductive outcomes for those outlier patients, which are quite a few. What we saw, and others were able to corroborate until now, that there seems to be a lower threshold of mid-luteal progesterone during a fresh cycle, which is approximately 5 nanogram per mil. But obviously, we await more results from our own and studies we are doing and intervention studies, but also obviously we need our findings to be corroborated by others. So just to finalize, progesterone is definitely the key to success. We saw this in our frozen embryo transfer. Remember, we gained 15% live birth rate just by monitoring our patients, not just by adding on. No one else did this since 20 years back in IVF. We spent so much money in our labs and our gonadotropins, and we just left these embryos alone. Now we learned the lessons and we retrieve excellent protocols. So the black box was the luteal phase, yes, but the agonist trigger opened our eyes and opened the black box. What we learned, which is so important in medicine, is one size does definitely not fit all, and this also accounts for IVF patients. Thank you very much.
My compliments, fantastic lecture, a lot to discuss later. We learned a lot, but we are still participating in the beautiful fighting. And then now we will move to the other side of the moon, which is the frozen embryo transfer. And we have Pedro Barri now, who will speak about luteal phase in frozen embryo transfer cycles. And then, dear friends, after that, we will have the discussion. Pedro, you know, he was the director of the Department of Obstetrics and Gynecology and Reproduction and the Institut Universitaire of Dexeus from 2004 to 2020. Since 2010, is the president of Dexeus Mujer Foundation, and since 2011 is the director of the chair of investigation in obstetrics and gynecology of the Institut Universitaire Dexeus of the Autonomous University of Barcelona. You know, he was one of the founder of assisted reproduction in general. I remember what we were doing in the beginning of the years 80, working on that one together with Bob Edwards. And I would like to remind that Pedro is not only a member of the board of directors of the European Society of Gynecology, which is chairing this webinar, but it also an important member of several academy and scientific societies. He had a huge number of publication. He have an even more huge number of participation to events in assisted reproduction. And today we have the pleasure and honor to have Pedro with us speaking about luteal phase in frozen embryo transfer cycle. Write your question, dear friends. At the end, it will be a firing moment. Please, Pedro, you have the microphone.
Thank you, Andrea, and thank you for to the European Society of Gynecology for organizing this educational activity such as this webinar. And it's a pleasure to be involved in this webinar and to share with our common friend Peter Humaidan this session. I would like to spend the next 20 minutes considering and trying to convince you about the importance of progesterone, of measuring progesterone during the luteal phase in frozen embryo transfer cycles. Great. I have nothing to disclose, and I would like to follow the pathway that Peter has opened, talking about the role of progesterone in assisted reproduction. And we know that progesterone has a crucial role in human reproduction because it's crucial for having a good implantation for three different actions that progesterone has. First of all, because progesterone induces the transformation of the proliferative endometrium into a secretory endometrium, and this increases the receptivity potential of the uterus. Progesterone has, as Peter has already said, plays a role in modulating the immune response at the uterine level. And progesterone is also helpful because it relaxes the uterine muscle and leaves the uterus cushion and more suitable for implantation. And of course, and Peter has not shown how important is progesterone supplementation in assisted reproduction. And I mainly will concentrate my talk in the frozen embryo transfer cycles. And as you know, normally we use two different protocols. One is a frozen embryo transfer cycle in a natural cycle, if the patient has a regular cycles. And in this case, there is also a luteal phase deficiency, and there is a need for progesterone supplementation, and especially in patients under an artificial cycle, in which there is no corpus luteum, there is no endogenous progesterone. In these cases, it's mandatory to supplement these cycles with progesterone. And why we are so interested in frozen embryo transfer cycle? Because we are wondering if this is the future in ART. In fact, in our center, classically, half of the cycles were ended in a fresh embryo transfer cycle, but the other half were frozen embryo transfer cycle. And look what the situation now in our department. And last year in 2022, more of 80% of our IVF cycles were frozen embryo transfer cycles. And if we consider in the oocyte donation program, it's 100% of our oocyte donation transfers are carried out in frozen embryo transfer cycles. So this means that most 80 to 90% of our embryo transfer are frozen embryo transfer cycles. And there is another reason for the increase in the number of embryo transfer, that frozen embryo transfer that we are performing in all our centers in the world, is that the cancellation rate, because no embryo survival, has significantly been reduced thanks to the efficiency of vitrification techniques. 10 years ago was quite common to talk to a patient saying, I'm sorry, madam, but the embryos, we have thawed them and none has survived. This is now something very, very rare. In our experience, it's less than 2% of the cases that we have to face this situation. And there are other indications why we are more commonly performing a frozen embryo transfer cycle. First, the single embryo transfer policies. And this, of course, is a helpful strategy. Another thing to be considered is the proliferation of freeze-all cycles for different reasons, for the prevention of ovarian hyperstimulation, for pre-implantation genetic analysis, for the idea of high progesterone levels at the end of the follicular phase that could interfere with the synchrony between embryo and endometrium, and in patients at risk of thromboembolic phenomenon, or patients with endometriosis, or in patients in which we have carried out a cycle of fertility preservation. What happened when progesterone is low before embryo transfer in frozen embryo transfer cycles? And we know that the classical work of Elena Labarta, what Elena showed in her publication was that in the oocyte donation model, they observed that the progesterone level, when the progesterone level was below their cutoff was 9.2, when the progesterone level was below this cutoff level, the ongoing pregnancy rate was significantly reduced in patients under an artificial endometrial preparation for oocyte reception. We tried to analyze our own data, and we performed a retrospective analysis looking at the results obtained in the transfer of euploid blastocysts, and we wanted to know if the progesterone level was important for the outcome of the cycle. And what Sofia Gaggiotti from our group showed was that when the patients were above our cutoff value, that was 10.6, was a little bit higher than the one published by Elena Labarta, we saw that there were no difference in the pregnancy rate obtained, but there was a significant increase in the miscarriage rate when progesterone was below this cutoff of 10.6. That translates in a final live birth rate that was significantly improved or better when progesterone was above this cutoff value. And here we can see how the significant were the difference in terms of miscarriage rate and in terms of live birth rate when progesterone was at a good level. And then at that time, we wondered if we could do something to circumvent this situation and to rescue this situation of risk of miscarriage and lower clinical live birth rate. And what we designed was a prospective study, again with the same model, single euploid blastocyst transfer. Patients at that time were under artificial cycle. Some of them received generase agonists, most of them did not. And the endometrial preparation was carried out with a combination of estradiol valurate and natural micronized progesterone. And we measured progesterone the day before embryo transfer because we wanted to have time to do something to improve the situation. When progesterone was above our cutoff value, above 10.6, we considered the normal progesterone group, and we proceed to the thawing of the embryo and the embryo transfer. when progesterone was below this cutoff value, patients were given an extra dose of sub-Q progesterone, 25 milligrams per day, and we measured progesterone again the day after. I mean, the day of embryo transfer. If progesterone was rescued above 10.6, we consider that it was a normal result, and we proceed with thawing and embryo transfer. If not, if the progesterone remained low, despite the administration of extra doses of progesterone, we decide to cancel the cycle. This is group of normal progesterone, group of progesterone rescue, and the group of poor prognosis. And in this prospective study, we were able to prove that when progesterone was rescued, the clinical outcome were totally normal in terms of low miscarriage rate and high clinical pregnancy live birth rate. And more questions came to our mind. And the first question was, is there a minimum progesterone level that should be reached for improved implantation? We wanted also to know how common is the situation of low progesterone level despite artificial endometrial preparation, and which is the advantage of serum determination of the day before, and if there are factors that we can predict in advance whose patient will present with low progesterone levels, and if low plasma progesterone level is detected, if there is, we wanted to know if there was a possibility strategy to overcome this. To the first question, I agree with what Peter has said just some minutes before, that if we look at the literature, we all agree that around 10 nanograms per ml for both, for natural and artificial endometrial preparation cycles, above these 10 nanograms should be reached to feel confident in having a good implantation potential. Another important point is the measurement of progesterone. And I go back again, like Peter did, to some data from Marco Filicori. There are classical data, but what Marco showed that was the fluctuation of progesterone throughout the luteal phase, and probably in parallel to the fluctuations of LH during the same period of time. And as you can see here, in the mid and late luteal phase, there are large fluctuations over the 24 hours study period. And this is why we wondered if a single determination was enough to clearly assess the luteal phase effect of the progesterone circulating in blood of the patients. And we, in order to have information on this, over this point, we analyzed, and Iñaki González from our group at the time, he published the results obtained in a group of patients, measuring, it would in fact were oocyte donors, and we measured, and in different times of the day, their progesterone levels. And what we realized is that there was a 44% decline on progesterone levels between 8 o'clock in the morning and 8 o'clock in the evening. This means that according to the time you are measuring progesterone, maybe you can have a false result. And this is why we standardize always the same interval between progesterone administration in frozen embryo transfer cycle and progesterone determination. The second question was how prevalent, how common is this situation? And in our experience, about 30% of the patients in both natural and artificial endometrial preparation cycles present with this clinical situation of low progesterone. And we analyze which could be the factors that can allow us to predict, to identify beforehand whose patients will present with this situation. And according to our results, we saw that all patients, obese patients, and patients with a low progesterone level in a previous cycle under artificial preparation of the endometrium, these three situations were clearly related to the clinical presentation of this low level of progesterone. This means that when we have a patient in front of us, we can predict if she's quite old, if she's obese, or if she has already had a low progesterone level in the previous cycle. Maybe we can advance to the situation and we can give her extra doses or higher doses of progesterone just to prevent this situation. So the age is important, the weight of the patient is important, and the previous history of low serum progesterone. And of course, the interval between progesterone administration and progesterone determination in blood. We also analyzed the results. We wanted to find out if even in natural cycles, the influence of progesterone was so important. And we observed that in natural cycles, using the same cutoff value, 10 nanograms per ml, as you can see here in this slide, there was a significant increase in favor of higher live birth rate when progesterone level the day before natural frozen embryo transfer cycle, when progesterone was above 10 nanograms per ml. And this is important, this clinical strategy of using natural cycle or artificial cycle, because we know from a long time ago, and now is a clinically important issue that is discussed in different meetings, is the correlation between artificial cycles for frozen embryo transfer and the later hypertensive disorders in later pregnancy. This is an old publication that we published in Gynecological Endocrinology some years ago, in which we analyzed the evolution of the pregnancies obtained in fresh IVF or oocyte donation and frozen IVF or oocyte donation. And as you can see here, there was a significant increase in the risk of hypertension in patients under artificial cycles. And there are more recent publications showing that the comparing stimulated versus natural cycles and risk of later hypertensive complication of the pregnancy, there was no difference. Comparing artificial versus natural cycle, there were difference in favor of natural cycles, and comparing program is the artificial versus stimulated cycle, there were also difference in favor of a stimulated cycle. And the reason is that in artificial cycle, there is no corpus luteum, there is no endogenous luteal function, and apart from progesterone, there are other components, other molecules, such as the relaxin, etc., that for sure will play a role in the genesis of hypertensive disorders in the later pregnancy. And just to go into the final part of my talk, I think, and this is very important, what Peter said, that we cannot only measure progesterone once and to act according to this value, because look at this Danish study showing the value of measuring progesterone on the day of beta-HCG determination. And as you can see here, there was a significant increase in the ongoing pregnancy rate when the progesterone level on the day of beta-HCG determination was above this value of 35 nanomoles. And this graph is really interesting because compares the clinical outcome according to different parameters. One is progesterone and the other is beta-ECG. And as you can see here, the better outcome is obtained when progesterone is high and beta-ECG is high. But look what happens here when beta-ECG is high and progesterone is low. Most of these, the miscarriages obtained in the group analyzed were in this category: good level of beta-ECG and low level of progesterone. And this means that we can do something. It's never too late, but the better you act, the better the results will be. And this is an interesting French study. It's in the oocyte donation model. And these French colleagues analyzed 3 different groups of patients. On the left-hand side, these patients did not receive extra doses of progesterone. In the middle, these patients receive extra doses of progesterone at the moment of embryo transfer. And on the right side, patients receive extra doses of progesterone when the beta-ECG was proved positive on the day of beta-ECG determination. And as you can see here, the risk, the risk of miscarriage was significantly reduced when progesterone was given, and was given early in the early luteal phase at the moment of embryo transfer, and the live birth rate was also significantly increased when progesterone was given early. And this takes us to individualize the approach that we present to our patients. And Manuel Alvarez from our group published last year a prospective study, again with the same single euploid blastocyst transfer, and we applied the same policy, measuring progesterone the day before. If progesterone was normal, we proceed with embryo transfers. If not, patients were given extra doses of progesterone. And if the progesterone was rescued, we proceed with embryo transfer. And as you can see here, even in the group of in which progesterone was rescued, no difference in the risk of miscarriage, no decrease in the live birth rate per patient. So I think that we succeed in rescuing this cycle that could, in other ways, could end up in a miscarriage. Quite often we are asked if there is an upper limit of progesterone that should not be exceeded. And this interesting meta-analysis show that the outcome according to the cutoff levels of progesterone. And as you can see here, when progesterone, in the upper part of this graph, when progesterone was low, below 10 or between 10 and 20, there was a reduction in the live birth rate. But when progesterone was between 20 and 30, or even over 30, there was no negative outcome, no negative influence. So I think that we should not be concerned about high levels of progesterone. And just to conclude, I would like to show you how clinically relevant is apply this strategy to follow and measure the levels of progesterone. And I would like just show you our miscarriage rate in our program from the year 2014 until the year 2018 in a quite heterogeneous group of patients. There is a group of 1,100 patients of normal IVF patients in frozen embryo transfer cycles, another group of 1,400 oocyte recipients, and a group of 473 IVF patients that underwent a pre-implantation genetic testing for aneuploidy screening. It's more than 3,000 embryo transfer. All of them are frozen embryo transfer cycles. And you can see here the miscarriage rate that we observe in these different groups of patients. When we start to apply this policy of measuring progesterone and establishing the policy to follow according to this value, we have half the miscarriage rate that we obtain in this population. And I think that this is clinically very, very relevant, because in the end, we will increase the number, the percentage of live birth rate in these frozen embryo transfer cycles. I think that we have time to do something. If we measure progesterone before embryo transfer, we have a period of time that we can improve the endocrinological situation of the luteal phase. Thank you very much for your attention.
Thank you, Pedro, for that fantastic piece of science. And also we're bringing up your experience. You are also showing us we are still in an evolution of what we are thinking. And just to make a comment before starting, also in normal pregnancies, for example, there are groups such my group who are evaluating progesterone after the beginning of pregnancy and are following the patients evaluating progesterone. And I think that what you have seen in assisted reproductive technology, either using fresh cycles as well using frozen cycles, correspond to what is the biology of human pregnancy, also in normal fertility individual. Then we will go on with the question. Please, we have received a huge series of questions. I will start. Okay. Then Ivan Martin Valencia, he asked, so father of IVF got it right when they decided to use HCG 10,000 unit. Now, if we use lower dosage of HCG, we must use additional HCG bolus?
So is this for me,
Yeah.
Andrea?
Yes.
No,
Yes,
I think that the problem, but he is right. You're right. The question is very well posed. Why did we end up with 6,500 instead of 10,000? Because you are right. In a non-OHSS risk patient, 10,000 covers the luteal phase significantly better. So maybe again, we should stratify our patients so that those with a low ovarian response will do very well with a 10,000 units HCG trigger if this is what we use. And I would not, and you know, in our unit, because we were doing agonist triggers, so 90% of our patients are agonist triggered, and then we modulate the luteal phase with small boluses of HCG. The problem with small boluses of HCG is that you need cutoffs to distinguish how much HCG you should give in the loop during the luteal phase. I would not add more HCG in a 6,500 units trigger patient. No, because this will invariably induce the risk of OHSS. But in those patients who are triggered with agonist, we have developed like an algorithm for the dosing and how many follicles, because I think we should all, the goal here is to avoid OHSS for all of us today.
Thank you. And then now, Pedro, is something for you. You were speaking about to have a progesterone supplementation in those patients who are already, for example, you are mentioning that they're already taking intravaginal progesterone. When you give a progesterone supplementation, you mentioned also the addition of subcutaneous progesterone. How we can manage? What do you believe? Because you know, also in normal patients, they have already received 3 times a day vaginal progesterone. How we can face this need of supplementation?
We have 2 options. Either these patients are given 25 micrograms of milligrams of sub-Q progesterone daily. Or what we do is we double the vaginal administration of vaginal progesterone. Instead of 200 milligrams every 8 hours, patients are given 400 milligrams every 8 hours. And so far we have, with both the strategy, high percentage of the patients, we succeed in rescuing progesterone levels the day after.
Thank you. And then,
Maybe Andrea, maybe I can just add, so we, since a few years back, explored the rectal route in these patients who are low, and the rectal route is a fantastic route. So, and even we're publishing a paper on this. We used the rectal route in quite a lot of patients as an additional, because in those days, we did not have the subcute, so it was available like 2 years ago. So we were using the rectal route, and you can definitely rescue, because there is also a limit, as Pedro says also, there's like a limit to how much the vagina will absorb. There's like a limit, so you can set up four pessaries, and at the end you will not increase the level above a specific point. But if you use subcute or even the rectal route, and the rectal route is actually preferred by our patients from the vaginal route.
Yeah. This is important, because I was surprised when we received the subcute preparation that most patients were happier with subcute administration than with vaginal administration, because they feel more discomfort with the vaginal administration.
Exactly.
This is something who happen. The women, they don't like to tuck their vagina. It's only the men. This is something which is we see as gynecologists, we appreciate. And then now I have another question for Peter. You were mentioning the cutoff of 10 nanogram per milliliter of serum progesterone in frozen embryo transfer and 50 nanogram per milliliter in fresh transfer for the highest live birth rate.
Yeah.
How you explain, because the life is the life.
It's true. And this is so wonderful, because this is physiology. Because the thing is that during frozen embryo transfer, you have like a physiological estradiol level. This is what we obtain with our tablets. And this is why the 10 nanogram per mil is the cutoff, which you also see during natural cycle. It's more or less like having one follicle. But in stimulated cycles, we triple or 5 times higher estradiol. And what does estradiol do? Well, estradiol is pro-inflammatory. So if you have high serum estradiol, you're also prone to having high endometrial estradiol. And these high levels will activate prostaglandins and cytokines. And the sum of this will be a progesterone receptor resistance. And this is why we need a 5 times higher progesterone level in our fresh transfer as compared to our frozen. Progesterone receptor resistance induced by estrogen.
Thank you. And then now, Pedro, we have two persons, Jasnet Kaur and Ivan Martin Valencia. They are both asking, do you believe that dihydrogesterone is a good rescue strategy?
There is a discussion on this regard, because we do not have experience in giving the oral dihydrogesterone for this kind of luteal support. There are some publications showing good results. Some others claim about the risk of giving dihydrogesterone to this patient. I would like to know, Peter, your opinion. Do you consider that both regimes are equal, or one is better than another?
No, again, I don't have the experience, but what I have the experience is we just now started trying to open the black box. And now someone comes in with a preparation that we cannot even measure. We cannot measure serum levels as it is now. And this is, from a clinical point of view, not very, I mean, everything else we can measure when we treat our patients. So this is why I'm quite resistant to oral, because I don't know how much do I get, and I want to know this specifically now when we are talking about cutoff levels. So like you, we didn't use it yet, and for me, until they come up with a test in which I can measure in serum, I'm not going to use it, frankly spoken.
And
Yes,
since
just to add something, we are using in normal pregnancy we are using in normal pregnancy also the addition of dihydrogesterone and 10, 20 milligram a day. And, you know, certainly, but also this, I totally agree with Peter and with Humaidan that the fact that we cannot measure, we don't find it in circulation. Then you have your progesterone and then you have the dihydrogesterone, you never know.
Andrea, the concern was about the safety of giving this patient dihydrogesterone. In your experience, you have not had any malformation recorded? No.
This is no. Certainly, when you go on safety, you need very huge numbers. You cannot make on personal history. On my personal history, since many years, we don't had any problem or any apparent problem about that. Then we have, then is there a question from Christina Tanase, Peter, Humaidan. Was it a reason benefit for a GnRH agonist before estradiol valerate in artificial cycles?
Well, we don't use it. And I think there are meta-analyses showing, again, for the standard patient, you don't benefit from a long agonist downregulation. But there might be patients like, although we do it another way but for instance, like implantation failure patient has proven to benefit from a Chinese study from long agonist downregulation. Some also in endometriosis patients would have a long agonist downregulation prior to a frozen embryo transfer. But for the standard patient, I think it's been proven beyond doubt that the patient does not benefit from a downregulation prior to frozen embryo transfer. This was the question, or was?
Pedro, do you want to add something on that point?
No, I read very recently an article studying the possible benefit of giving long downregulation with GnRH agonists in patients with adenomyosis that had been suggested. And the final message of this article was negative. They failed to show any benefit in giving depot agonist preparations to patients suffering from adenomyosis before receiving frozen embryo transfer cycles.
And Janet Kaur is asking, what is your progesterone threshold when using injectable progesterone in fed cycles?
Peter?
Well, I think the thing is, if you use 50 milligrams of progesterone IM, you're going to go very high in progesterone. So I cannot say that there is like a cutoff, and this probably supports what Pedro was saying. The question is, can you go too high? Probably not, because the Americans have been using and still use IM progesterone in a lot of patients, and they have excellent pregnancy rates. So I could just say that if I use IM progesterone, I usually do not monitor, because I know that the level is prone to be way above 10 nanogram per mil in frozen embryo transfer.
And then also, now I have a question, Pedro, an anonymous, right? I have a patient with low FSH 0.3 and low LH 0.4. And what happened? He have done the stimulation with gonal 300 unit, but there was no response, something that we know already since the past. What is your opinion to do what in this case?
Well, I think this is a different issue that we are discussing today, but yes, it seems that is a hypo, no?
Yes, hypo.
I don't know, we have to look at other parameters such as the antral follicle count, the AMH, her body mass index.
Also, we have to remember that hypo have very low estradiol concentration, and then I think you have to make a cycle of slight stimulation of only estradiol to promote also the rise of estrogen and progesterone receptor 2, you know, because
maybe, or giving extra doses of HMG or giving extra LH during stimulation.
You have to make a personalized
Absolutely.
And then with this question now for Peter. Oh, I'm sorry, I will have here is is doing. According to you, which is the most optimal handling of the endometriosis patient, fresh or frozen embryo transfer?
Well, I think this is an interesting question, and it's probably still up for debate. I can just say that there are French studies, and I think more and more people agree that we should go for frozen embryo transfer in these patients. Why? Well, and this has been established by Leslie in US, that if we go for endometriosis, these patients have a progesterone receptor resistance because they have higher estrogen levels in their endometrium. So imagine you have a patient who at baseline has a degree of progesterone resistance. Now we stimulate her and we increase significantly her estrogen levels. And so we will also increase the progesterone receptor resistance. So what we did since quite a few years ago was all endometriosis patients will have a segmentation cycle. So we will stimulate, and it also gives you the freedom of stimulating quite hefty trigon with agonist, do segmentation, get some nice blastocysts, and then transfer in a frozen embryo transfer cycle. So this is what would be my recommendation. Obviously, we still need studies like control studies, randomized control trials, comparing fresh embryo transfer to frozen. But I think from a physiological point of view, it makes sense, and we have the data to support it.
Thank you, Peter. And then, Pedro, you want to add something on this
No,
point?
no, I totally agree with what Peter said. Totally.
Then one question from Pu Zhang, Pedro, for you. When should the blood test of progesterone be taken? Clock 8 on the morning or any other hour?
No, I think you have to establish your internal protocol in telling the patient when to administer progesterone. And for example, we always suggest the patients to have the blood sampling between 8 and 9 in the morning.
Thank you.
Before the progesterone administration in the morning. And
Perfect.
at least 4 hours apart from the last progesterone administration. This is our protocol.
Yeah, and I agree totally with Pedro. We do the same, but we say 4 hours, no more than 4 hours after the latest vaginal administration. Yeah.
Absolutely.
Because as you were saying, Pedro, the most important thing here is to have a standardized system in each clinic and then keep the standard so you can rely on these
Totally agree. Totally agree.
And then also, but probably you have already answered, Peter, to that question. If you have got a cutoff serum progesterone level for the endometriosis patient, and it is different from the non-endometriosis.
It is, and we actually published this quite recently in RBMO in a cohort study of more than 260 patients, all endometriosis patients. We did logistic regression analysis, etc., and we found an odds ratio for live birth of 2.1 in patients with above 40 nanogram per mil in a frozen embryo transfer cycle. So just telling you again that even though we do frozen embryo transfer in these patients, at least in our hands, they benefit from 4 times higher progesterone levels as compared to standard patient. So again, showing us that we need to individualize our patients also for frozen embryo transfer in terms of the diagnosis that they have. Again, we need more studies, but this was more than 260 patients recently published with Christopher. Yeah.
Thank you. And then, Pedro, for you, is the luteal phase support with progesterone useful in natural fat cycles with the corpus luteum therefore present? Because there are conflicting data in literature.
We, in patients under natural frozen embryo transfer cycles, we suggest the patient to receive extra doses of progesterone when ovulation has been detected. But they are given 200 milligrams every 12 hours from the day of ovulation.
Thank you. And then, Peter, for you, in natural cycle is not very consistent cycle to cycle even in regular patient. Why risk it? Maybe use a based tamoxifen stimulation. It is very cheap and the luteal phase progesterone levels are very good. What do you believe about?
No, obviously you can do this. Letrozole, yes. Tamoxifen, yes, you can use this. But I think the new thing which is coming, which I think you all heard about, is this modified natural cycle. There are studies have been published, and I think there's a large study from Portugal coming out, which uses, obviously this is for normal cycling lady, but which uses the natural cycle until the size of the follicles is 15 millimeter. And then there's a direct shift. Then patients will be supplemented with vaginal progesterone onwards. So this gives you a high degree of flexibility. You just use the corpus luteum because there will be an ovulation induced by the vaginal progesterone, and you will have the relaxin that Pedro and all the other substances. And this study, this protocol until now seems to prove a lower risk of hypertensive disorders using frozen embryo transfer. But I agree with the previous person. Yes, you can definitely stimulate. You can also do low dose stimulation, low dose FSH stimulation, but tamoxifen or letrozole is fine. Yeah, I agree.
Thank you. Thank you very much, Peter. And then Pedro, sorry. This is from Elena Rota. So should we always test LH or progesterone level before transfer?
No, progesterone. We only measure LH, and for practical purposes, we measure LH in urine in patients under natural cycle. Okay? But in patients under artificial endometrial preparation cycle, we do not measure LH, we measure just progesterone.
Thank you. And then, okay, and then that one from Janet Kaur. What is, Peter, what is the ideal time to measure serum progesterone when using injectable progesterone in fed cycle? Same as 6 hours as suggested by Labarta's group when using vaginal progesterone?
Yeah, well, I think so. No, I think we say here more than 9 hours after the latest injection, because it gives you a huge rise. So usually it's like taking the injection in one day and then, well, in the evening, and then we would measure in the morning, but we don't use a lot of IM progesterone any longer because we either use the subcute or the rectal route.
Okay, then okay, then Pedro, Tefik Yoldemir, should estrogen level be checked during FEC together with progesterone?
Yes, we we do. We measure. We have 3 parameters: estrogens, progesterone, and endometrial thickness. Are the 3 parameters that help us to feel confident that the uterus is receptive. It's true that we haven't paid great importance, or we have looked in depth estradiol influence, but and we have focused mainly on progesterone. But probably, and it's very interesting what you said, Peter, about the inflammatory molecules, cytokines, etc., that can play a negative role in the embryo-maternal dialogue, and the direct correlation between high or too high estradiol levels, maybe even in the context of frozen embryo transfer cycles, and an abnormal situation and abnormal scenario at the pro-inflammatory molecules at the endometrial level. We have not, we are in the process of analyzing our correlations between estradiol, progesterone, clinical outcome, but I think that we have to pay more attention to estradiol as well.
Peter, you have a comment on that?
No, I totally agree. I think estradiol also plays a role, and maybe in specific for groups for some patients. So Pedro, what is your cutoff for estradiol in those frozen embryo transfer cycles?
Here we consider that a minimum of 150 picograms per ml.
Yeah.
Patients are given 6 milligrams per day.
Yeah, which is more or less what a normal corpus, a normal follicle would produce, one follicle.
Absolutely, at the periovulatory phase.
Yeah.
And also, I have to tell you that in this period, when you have so many difficult patients who approach also natural pregnancies, also in natural pregnancy to avoid miscarriage, we have to take care of with some strategies evaluating both estradiol and progesterone. In the natural pregnancies, also beta HCG, in addition to the endometrial thickness. They have, I think, in this moment where the pregnancy is so rare, and it's so important when it's achieved in an age so advanced, I think it's very important that we take care what is the biological situation. And then now we are approaching to the end, but we have Enrique Perez de la Blanca for both excellent presentation, thinking about a certain progesterone endometrial resistant in adenomyosis. Did any of the works you have revised have into account if patient with adenomyosis or endometriosis or both behave the same with similar level of progesterone as the other patient? You were, Peter, telling before that they have a different sensitivity to progesterone. Please, can you make a comment?
No. So, Andrea, so the question is, will there be a difference between adenomyosis and endometriosis? Was this the question?
No, the question was if patients with adenomyosis or endometriosis behave the same with similar level of progesterone as patients without endometriosis or adenomyosis.
Well, again, I just have to refer to our study showing that you need significantly higher progesterone levels for these patients. So it's nearly 4 times higher in this study, which is already published. And this is the way we work. So when we monitor these patients, we want them to have like 40 nanogram per mil on the day of blastocyst transfer in comparison with 10 nanogram for the others. And by this, because this is what our analysis showed, again, let's await some more data from others, but this is how we work clinically today with this group of patients.
Pedro, do you have any comment about on that?
No, I agree with Peter, totally agree.
Oh, okay. And then I think we are at the end. We are approaching to the end. Then we would like to have, as we do, a personal comment. After this beautiful presentation, what happened in IVF cycles, in fresh IVF cycles and in frozen IVF cycle, you were mentioning a strategy that each one of your group have to follow to obtain this result, because you have obtained the results achieving pregnancy in 40, 45, 50, 55, 60% of the patient coming. And if you go to see the real numbers of the majority of the centers in the world, they are far from that. They are far from that. Then I would like your last message concerning the fresh IVF cycles. Peter, please, if you have, you can give something from the heart, from the heart.
So something from the heart is, we just started opening that black box of the fresh transfer cycle. But if you have patients who were transferred repeatedly with good blastocysts in fresh transfer, I would definitely say go for frozen embryo transfer, because they might be those outliers, and they were like 2 out of 10 patients. This is like 20% of patients who were there, and they should definitely not waste those wonderful blastocysts in a fresh transfer, but go for frozen embryo transfer if you have a good lab.
Thanks a lot. And then now, Pedro, your message.
My message is do more frozen embryo transfer cycles. It has been said that thanks to the agonist, we were allowed to avoid working on weekends, etc. No, do the aspiration on the right time, and you can schedule the embryo transfer for whenever you want. The physiology we will be much more respectful with physiology, using either natural cycle or artificial cycle or mild stimulation cycle, but with frozen embryo transfer cycles.
Thank you very much. And then my final message, and also take care that in normal pregnancy, in difficult patients, in patients, aged patients, or patients who have any of those gynecological problems such as endometriosis, adenomyosis, or also had previous pregnancy loss, take care of them. Make also the same kind of essay to evaluate what is the biological situation and support them with the possible best product that we have. Then, dear friends, thanks to Peter. Thank you, Pedro. Thank you. It was a great day. It was a great day for the European Society of Gynecology. We enjoyed a lot. And I would like to invite you. Next time, we will speak about progestogen in luteal phase supplementation and hormone replacement therapy. We'll have two masters, Johannes Hott from Austria and Alfred Muck from Germany, the Tuesday, 13th of April, always 15 Central European Time will be the webinar. Then, dear friends, thank you. I remind you that the European Society of Gynecology will have its own Congress in Amsterdam, 29th of November, 2nd of December, 2024. Enjoy the life, take care, and I want to thank our masters. Thank you, Peter and Pedro. Thank you.
Thank you, Andrea. Bye-bye.
Goodbye from Madonna di Campiglio, Pedro.
Bravo, bravo.
And thank you for your enthusiasm, Andrea.
Yes, thank you, Peter. Enjoy the life. Bye-bye.
Bye-bye.
Bye, dear friends.